at CHES, where she was an academic general pediatric fellow. So she's going to speak to us a little bit today about some of her work on pursuing equitable care, risks and opportunities for inclusive and anti-oppressive research. Dr. Li, thank you for joining us.
Thank you so much for the opportunity. I'm just going to share my window here. Okay, I think you see the presentation. That's good.
Yeah, perfect.
Perfect.
Super. Thank you. So first, I would like to start off with a land acknowledgement. So I'm speaking to you from the unceded and unsurrendered territories or lands of the Kanien'kehá:ka, which has long served as a site of meeting and exchange amongst many First Nations, including the Haudenosaunee and Anishinaabe. And as a first-generation Chinese immigrant and settler, I am grateful to have grown up and be living in Shoshaque and commit to upholding and implementing Joyce's principle, which I've put up here, within our department and institution through initiatives led and working in concert with our Joyce's principal ambassador, Dr. Samir Shaheen Hussain. And once again, I put Joyce's principle up here to remind us all to reflect on what we're doing individually and or collectively to address the past and ongoing anti-Indigenous racism that is occurring in healthcare and within the walls of our institution. Joyce's principle was named after Joyce Echaquan, a Atikamekw woman and mother who died a brutal and avoidable death in a Quebec hospital as a result of anti-Indigenous racism. So I want to acknowledge as well a lot of my collaborators and team members. Many of these ideas that we'll be talking about and slides as well have been developed as a team. So here is the team for the Equity, Diversity, Inclusion, and Indigeneity for POPCORN, which is the Pediatric Outcomes Improvement through Coordination of Research Networks. It's a network that spans across pediatric hospitals in Canada to research on COVID and to conduct other multi-center research. So these are some of my co-conspirators, as well as other colleagues that work with me closely at the Montreal Children's Hospital, and also obviously acknowledging that a lot of the ideas that I share are from, you know, brilliant health equity scholars and scholars from all disciplines. That I will be sharing with you today. So essentially, the objectives are to discuss the context for calls to address health equity in clinical and practice research, to discuss some approaches and reflections on inclusive and anti-oppressive research by sharing two experiences from two studies, POPCORN, which, as I mentioned, is a platform for COVID-19 and multi-center research studies in the Canadian pediatric hospital setting, as well as another study that we're leading to co-design a patient navigator intervention to address barriers to care for migrant children and youth with special health care needs. So, you know, there have been a lot of calls to pursue health equity in the clinical practice and research setting. And more recently, these have been propelled by the COVID-19 pandemic, the Truth and Reconciliation Commission calls to action, Black Lives Matter, George Floyd, Joyce Echaquan, tragedies and brutal deaths of the latter two. And this is nothing new. There have been a vast body of literature that have existed in the US, which were highlighted in a 2010 American Academy of Pediatrics report on racial and ethnic disparities, where they looked at literature between 1950 and 2007 and reported on disparities in children's health and healthcare that spanned across a wide range of outcomes and health services, being mortality rates, access to care, use of services, prevention and population health, health status, chronic diseases, anything, you name it, it was there. And they concluded in that report that disparities are extensive, pervasive, and persistent, and occur across the spectrum of health and healthcare. And these are rooted in racism, discrimination, and social determinants of health. And in the clinical setting, these current events and this growing body of literature has translated to various actions in an environmental scan that was led by one of our pediatric residents locally at the Montreal Children's Hospital, looking at how health equity is currently being implemented in the Canadian pediatric hospital setting. We use the IHI, which is the Institute for Healthcare Improvement Framework, for healthcare organizations to improve health equity. And essentially looking at how things are being operationalized. We know that approaches to health equity are in evolution and in different phases of maturation. So we've got some institutions across Canada where we've got, you know, a strategic vision and plan that is being implemented at a more leadership level. We've got other institutions where there's a lot of local champions that are more reactively trying to create programs or interventions to address health equity locally. And we do see that there are, once again, reactive approaches to recent events. And that unfortunately there's a lot of work going on, but that even within institutions, there are a lot of people working in silos. So, and not necessarily collaborating or talking to each other. So we've got, you know, things going on for training or implementing EDI principles at the university or the faculty level and medical education level. And then you've got various other things going on at the hospital level and then at the provincial level, etc. And lastly, one of the key findings from this environmental scan, which I forgot to mention, involved interviews with 2 to 3 kind of health equity leaders at each of the 16 pediatric hospitals across Canada. One of the last kind of themes that came up was the gap in health equity related data collection that is going on in our hospitals at the moment. And this has previously been identified as an issue in a study conducted by the Solutions for Patient Safety Network, which involves 125 US hospitals and 6 Canadian hospitals. And in their kind of survey that ran between January and March of 2018, of the Canadian pediatric hospitals that participated, 5 out of 6 did not collect race and ethnicity data, compared to the 100% or 88 out of 88 of the US hospitals that did. Of course, there's a different kind of political setting and drivers in the US that makes this kind of complete variation kind of the reason behind this. And then at the same time, in the Canadian pediatric hospitals, 2 out of 6 did not collect language preference data. Sorry about that. And now kind of bouncing back to the research kind of setting for health equity, there have been many calls that have been made to also push health equity in the research agenda through our main Canadian health research funding body, CIHR, which in their 2021-2026 strategic plan states that health equity remains the most pressing health-related challenge in our country. And in their strategic objective D, the pursuit of health equity, their strategic objective D is the pursuit of health equity through research. And so through these calls, what has translated into action is essentially in funding calls, there's many kind of check boxes and requirements for teams to have an EDI champion or to have an EDI team or an EDI plan on their projects. And so it's become quite a buzzword, and not only in kind of the funding agency calls, but equally in calls from journals for proposals or manuscripts that address or look at health equity. The problem with that is that, unfortunately, many academics have minimal to no training in health equity or lived experiences with marginal identities. And this goes throughout kind of the team in terms of the investigators, the research staff, the review teams that are looking at the grants, the editorial teams that are kind of gatekeeping what's published where and how they're published, how things are being communicated, and as well as supervisors of trainees and other kind of team leaders that are training essentially the future of healthcare research. And so this really kind of puts into question how this high quality research, which is meant to benefit equity deserving communities, is being ethically reviewed, conducted, and disseminated. And also brings into question the idea of health equity tourism, which unfortunately does happen. And this is a kind of idea that was brought forth by Dr. Lett, in which investigators who previously did not engage or have any kind of knowledge of health equity research launches their research program without the expertise that is required to conduct high quality health equity research. And oftentimes it is to help boost their personal academic productivity. And some of the harms of this is that, unfortunately, if we disregard history and don't understand the context of how scientific inquiry has caused harm to communities, we can further perpetuate these harms. That research is then done on communities rather than with communities. That we also end up parachuting into marginalized communities to conduct research, that we kind of try to, use existing structures and adapt what we have already to fit into health research that is addressing inequities without really investing in what's needed to do appropriate and transformative health equity research. And then kind of, doing the same kind of research of producing findings that can misinterpret the needs of certain populations, where we might, mischaracterize the root causes of health inequities and further perpetuate kind of disparities, as well as create further mistrust, which can exacerbate relationships. And, there are many kind of identified and many more unidentified examples of how health disparities has been harmful when applied. Health disparities research has been harmful when applied in the pediatric care setting. And a widespread example of this, which is not unique to pediatrics, but certainly there are cases in pediatrics, is how race is used in research. And as we know, when race is identified as a risk factor or a biological marker, it can further oppress communities where poor health outcomes were actually a result of racism and other structural determinants of health, such as healthcare access or healthcare insurance, rather than just it's not really because of the race, it's because of racism. One example of this is the 2001 American Academy of Pediatrics urinary tract infection guidelines, which were reaffirmed in 2016, where it was listed that a risk factor for whether you would go ahead to test a patient for a urinary tract infection was whether they were white race for girls or non-Black race for boys. And stemming from a lot of criticism for this, the AAP is currently undergoing a review of all their policies, guidelines, and algorithms to look at how they have inappropriately used race and try to correct this. Similarly, New England Journal of Medicine has also stated recently that they are also trying to confront biases and injustices that their journal has helped perpetuate, and they're producing a series of articles looking at their own publications and once again how they have caused and contributed to harm. At the same time, it's not that collecting race-based data is all bad. And an example of an intentional and appropriate use of race and ethnicity data to reduce disparities is this one recent study that came out from the Hospitals for Solutions for Patient Safety, where essentially they looked at patient safety outcomes based on race and ethnicity identity. And they demonstrated essentially that multiracial Hispanic, combined Hispanic and Native Hawaiian and or other Pacific Islander children had central line associated bloodstream infection rates that were 2.6 to 3.6 standard deviations above the reference value. And for Black or African American children, unplanned extubation rates were 3.2 to 4.4 standard deviation above the reference value, whereas the rates of both of these events, being central line infections and unplanned extubation rates in white children, were significantly lower than the reference value. And I guess in this example, I wanted to really highlight how the authors kind of communicated their results in that they have not centered their outcomes on kind of whiteness, on, you know, comparing white versus all other racial categories, or kind of having a binary division of the two. And essentially comparing outcomes to the reference value. And this is a group that, you know, has a good history of using their information and their data to work on interventions to improve outcomes. And so I think their goal was to identify kind of whether there were disparities that can contribute to patient safety events. And then as a second step, to look at where the structural and individual kind of biases may be that lead to these outcomes in order to then develop future quality improvement interventions. And I think the important thing to know about this particular kind of looking at these patient safety outcomes in this setting is that there's, you know, it's very unlikely that it's upstream factors that caused or resulted in unplanned extubation and central line infection rates. So really, these are outcomes that are hospital acquired and due to, once again, issues that happen in the hospital due to either structural or individual biases or approaches to things. And so going back just to the idea of health equity tourism, at the same time that we don't want to ourselves be involved in health equity tourism, I think it's important to also say that there is a lack of diversity in existing health research. And this is widespread. So among 20,000 US-based trials that were in the clinicaltrials.gov database over 2 decades, only 43% reported on any race and ethnicity data, and most participants were white. Further, in randomized controlled trials published in high-impact journals between 2015 and 2019, less than 15% reported on socioeconomic status of their trial participants. And focusing on pediatrics, there was a study that looked at that reviewed 3 high-impact pediatric journals, so basically the top 3 high-impact ones between 2012 and 2021. And once again, looking at language, inclusion of non-English speaking participants, only 9% of the articles of the total 5,000 articles included non-English speaking participants. Whereas, you know, looking at where these studies were mainly published in the USA, about 9% of the US population speak a language other than English. In another kind of review, authors looked at all of the funded studies in the CIHR database from 2009 to current, which was about 2021 at the time. And they found that there was a lack of CIHR funded research, so less than 2%, and high quality evidence, so RCTs involving migrant participants. So essentially, we know that research participants do not represent real world demographics, and that this kind of lack of research involving equity deserving communities lead to healthcare structures and practices that further privilege white and majority populations. And so just to be sure that we're talking about the same thing, who are these equity deserving communities that we talk about? So essentially, they're groups that, may share unique experiences, geography, culture, identity, language, relationships, and essentially experience worse health outcomes than the average. And often, the reason for these worse health outcomes are due to racism, colonialism, discrimination, and barriers to accessing resources and opportunities. But of course, one community may involve diverse communities. And here, this is a slide that one of our presenters, Josh Swain, uses in our presentations to talk about basically, even within our Indigenous or First Nations populations, we're talking about a very diverse community living in, some remote areas, some living in urban areas, sharing very unique experiences and cultures and perspectives. And with the idea of diversity within a community is also the idea of intersectionality of each each individual in that community, which, as you know, represented in the former slide with here with Stephanie Nixon's kind of coin model, that we all hold positions where we are on top of the coin. We have certain positions that make us privileged, and then other positions that put us to the bottom of the coin where we are disadvantaged. And each of us have, once again, different identities that may place us at a privilege and at systems of oppression all at once. And that these positions then equate to systems of inequality. And there was a really fresh off the press article that was published last week from colleagues in Canada discussing the importance of intersectionality in looking at kind of the experiences of anti-Black racism. And in the Canadian setting, what these authors have highlighted is that, in Canada, in 2021, the Black population was very diverse and very diverse and diversified, involving 300 ethnic or cultural origins, 450 first languages, and varying in religion and immigration status. And looking even in 2016 at different intersectional identities, once again, 18% of Canadian-born Black men had a bachelor's degree or higher versus 31% of Canadian-born Black women. And so these sociodemographics and positions interact with race in complex ways, as the authors describe, how each individual may experience or perceive racism, and in how racism manifests towards these individuals as well. And some examples that they give are, a recent immigrant or a recent arrival, a Black person who's come from an African country recently versus someone who's been born and raised in Canada, they may perceive racism differently and may also experience it differently. And so I wanted to move on to then talk about two examples of how we've tried to conduct inclusive research and implement principles of EDI into our research. And once again, I think these are kind of, in talking to you about these, it's not at all in saying this is the way to do it and or say that we did it very well. I think it's to share our experiences and talk about how we're all on this path and this journey to try to learn more. And so Popcorn, as I mentioned, is a network of networks that involves 16 collaborating sites, so all the pediatric hospitals, as well as all of the main hospital-based pediatric hospital networks, research networks. So here we have PERC, which is the emergency network, PERN, which is the inpatient network, CCTG, which is the critical care network, as well as a few of the infectious diseases networks. And Popcorn has several pillars that include kind of cross-cutting methods, data governance, biobanking, shared resources in terms of streamlined ethics, data coordinating centers. And throughout all of this, we have the EDI plus I and the community and patient, parent and youth engagement teams. And here are other members of our EDI plus I team. When we set out to kind of embark on this journey, we had a few objectives. We wanted to harmonize our data collection on health equity measures. We wanted to have a community-based interface and engagement to ensure inclusivity and engagement of participants in our research. We had some ideas around conducting qualitative studies on experiences of health equity deserving communities during the pandemic, to foster Indigenous partnerships, and to also lead a team and train a team on kind of anti-oppressive research. And so we did this by trying to embed EDI principles and by having a parent and youth engagement throughout our processes, from the grant proposal, where we had a parent partner as a co-principal investigator, as well as others who reviewed the grant and objectives. Many of our parents and youth also helped us review our questionnaires and our data collection tools, and specifically those involving our sociodemographic data collection. They were also involved in reviewing our data governance and access policies. And for some of the studies that have finished, the youth were very much engaged in the data analysis, interpretation, and now the knowledge mobilization. And for the other studies that are now ongoing, our team is there to support the final stages of the research. And so kind of ways that we've kind of conceptualized it, and I'll show you how we have and haven't been successful, is that we've tried to really involve community representation on the research team and try to, represent in the research participants, and to really try to implement principles of equitable, accessible, and culturally safe participation. And in the next few slides, I'm going to talk a little bit about some of the kind of principles of how to conduct inclusive research, which I'm pretty sure through your other kind of noon rounds, these principles have been discussed, but I'll just review some of these. That essentially, we could have from a very minimal interaction with the community, where we reach out to them to help give some information and services, to really consulting them and getting their feedback on certain aspects of the project, to then involving them more to the point of having a shared leadership model where they truly are partners in the research with us. And in a systematic review of clinical trials, less than 1% of patients were actually engaged in research. So it's rare to go all the way to the right side of the spectrum where there's shared leadership, unless really, the study was designed to be as such, to be a community-based participatory research or really co-designed project. And we talked a little bit about this. And I guess that's part of the question that I've been asking myself for several years, and also throughout the Popcorn study, does all research need to be community engaged? Oops, this is not, sorry, this got moved out. So this is just a very preliminary kind of discussions that I was having with Dr. Walker and her colleagues at McMaster, Jennifer Walker, in terms of, this idea that, how much community engagement do we have to have in our research? And especially when it pertains to Indigenous research. So once again, I was talking about in the setting of popcorn in particular, where we are conducting research that's not focused on Indigenous communities specifically. We are recruiting children from across Canada that are walking through our hospitals with the diagnosis of COVID or similar symptoms. And so we want to be sure to implement the principles of EDI and IR, which is, equity, diversity, inclusion, and indigeneity and reconciliation into our research to ensure that we have, once again, inclusive research and that we are not further harming and further causing disparities. And so we're not really doing the kind of the far end of the spectrum where we're doing research that involves self-determination and sovereignty of Indigenous populations. And that research should be led by absolutely Indigenous scholars and colleagues and communities. And similarly to that, if I go back to this model, there are certain for other research involving equity deserving communities, it's that same idea of where the research is really centered on the community, then it is really important to have that shared leadership and to conduct and to implement principles of community-based participatory research. Whereas when we really want to, involve and ensure EDI principles, it's important to involve and collaborate with communities, and especially throughout the process where they may be involved. And I'll talk a little bit more about that in the subsequent slides. And so this is the idea where when a study is not designed to be a community engagement study and it's not grounded in CBPR, there are certain guides that are available to help researchers on how to make research more equitable, diverse, and inclusive. So this includes the National Institute for Health and Care Research Toolkit. There's one that comes out from the Multiple Regional Clinical Trial Center of Brigham and Women's Hospital and Harvard here to the left. NSERC has some guides on how to integrate diversity, equity, inclusion into research. And other ones that have been developed in the UK. So there's Rep Equity and also Trial Forge, which asks, it's nice, and I'll go through some of these questions of, what are the questions you need to ask when you are about to design a research project to ensure inclusivity. So this is the Rep Equity Toolkit checklist. And this is the NIHR resource that when you click on each of them, there's kind of questions to consider from the beginning to the end of research, thinking about the historical context, patient community involvement, the research team, selection of participants, data analysis, interpretation, dissemination, and budgeting. And so I've kind of integrated all of these tools into one slide to essentially demonstrate, how we can, or how we could implement these into each of our research questions and research projects. So thinking about the historical context and structural inequality, how do these impact research involvement of participants? Has previous research excluded certain populations? And then really being proactive about this and thinking about how one would navigate these issues. In terms of the objectives, to think about what is the aim of the research study in relation to representativeness and equity, and the participants, who's actually being represented, what are the relevant goals of the relevant equity deserving groups, who should my trial or my study results apply to, and am I going to be able to recruit these people, and what are my goals to recruit. And if I have issues, being funding, being timelines, being you know, a lack of sites that have the diversity or that I need, how do I try to address these external factors and manage them? In terms of data analysis and interpretation, same thing, you know, how do we analyze and report EDI characteristics in a way that doesn't further marginalize groups, and how do we have diverse perspectives help us to support the interpretation of these results. In terms of dissemination and implementation, will they be disseminated via an accessible and inclusive formats and channels? And how will the research actually be taken forward to benefit the users? How will it be taken back to the communities, and not just kind of published in a journal or presented at conferences for academics and clinicians? And will the most in need be impacted by our research? Budgeting is also a consideration, once again, to you know, to ensure that we are able to address a lot of the barriers that we may encounter in trying to implement inclusivity in our research, whether it be ensuring that we have appropriate interpretation translation costs, or that we allow for the extra time to that it takes to engage with communities and develop partnerships and develop trust that would be needed to carry the research. One of the really nice kind of questions that came out from one of these guidelines and articles that I think should be kind of overarching all of our research is, how can this work cause harm? So even if it's a trial that's focused on a very generic condition that may or may not necessarily be focused on any particular community, all of our studies and trials should take into consideration whether the study in itself can cause harm because of the fact that we've inadvertently excluded important populations, and or that we've included them and somehow interpreted the data in a very deficit lens. So going back to our popcorn project, let me just double check where I am at. So, you know, we strive to create a research platform for COVID that, you know, would really try to be inclusive, that wouldn't further widen the disparities gap, but we were kind of, you know, realistic and honest in what we're able to achieve and what we were not. So first of all, you know, this was a funding call that came out. We had a few months to put it together. It was very much in, you know, academic led, and, you know, we involved as many communities as we could from previous relationships, but still we're talking about, you know, hospitals across Canada where there is a huge heterogeneous community with many identities and intersectional kind of positions. So, you know, to truly be inclusive is kind of not realistic. We had little data to kind of guide us on, you know, which population were actually seeking hospital care for COVID in the pediatric hospital setting. And so we kind of didn't know what we were kind of trying to aim for in terms of inclusivity. And because of the waves of COVID, we had to be quite opportunistic in that we would, you know, recruit when we could and recruit when we couldn't. And that the recruitment process was also very in terms of developing trust with our participants, it's not easy in the setting of an acute illness like COVID. It's not a long-term disease where, over time, participants can really understand the research process and engage in the research. We try to, as much as we can, with our patient engagement and our knowledge mobilization team, which have really tried once again to work with families and youth to ensure that we have ongoing relationships. But with the actual participants, it was kind of one-time measure, 3 time points. And so it's hard to really understand how did our research staff really engage in developing relationships to try to seek the participation of various communities. What next did I want to talk about? And I guess I also wanted to highlight, that we also worked on ensuring that we also had proper data governance and access policies to protect data on health equity deserving groups and to promote health equity. And then along those lines, we had, written into our data governance documents, the fair and care principles, as well as some of the others that are available, like the one published by the Black Health Equity group in Ontario, with respect to engagement, governance, access, and permission of data, and the OCAP principles. But I think there's a lot of challenges in how these are actually implemented, because you do need a team and people who are, very carefully and conscientiously following the implementation of these governance and access principles. And I don't know that we have perfected in doing this. And in speaking to Dr. Gutman and Dr. Astrid, I understand that the Institute of Clinical Evaluative Sciences is also developing their documents on this. So we're looking forward to learning from different research organizations, institutions, and teams on how we actually implement these ideas. I'm going to try to skip ahead a little bit faster, but the other kind of endeavor that we sought out to do was to really train our team, recognizing that a lot of individuals were getting trainings from different venues, and that they were not always interactive, not kind of focused necessarily on research and the principles of research. So we developed this training to address this gap, where we kind of co-designed with our users, assessing what their needs were, to look at implementing these workshops, which we actually we rather call them kind of co-learning sessions rather than workshops, because we are constantly learning with each other during these workshops. And I'm going to go back here. And really, our objectives were to critically think about how health inequities are created and sustained through systems of oppression, to consider methods, interventions, and directions to advocate for health equity and social justice through health research, and really to engage in and facilitate difficult conversations to promote unlearning and solidarity. And we call these not safe spaces, because it's hard to create these safe spaces, but we call them co-learning sessions where we have brave spaces to discuss these issues. And I'm going to skip some of this. And we were able to then, not only share these co-learning sessions in our network, but also with other pediatric networks, and where we had some very nice feedback. So we're very kind of excited about these co-learning sessions, where I think we're further developing them and further working with other institutions and research networks to tailor these kind of trainings. And we're thinking about what's the next step for this, because we are trying to build more capacity for this essentially, so that it's not just a few groups doing this, but everybody in their research teams is able to engage in these training sessions for their own research settings. So now I'm going to switch to a project where we did focus on a particular population and community. And this is the example of a co-designed RCT for patient navigators for migrant children experiencing healthcare transitions. And sorry, these are my co-PIs, Dr. Shazeen Solman, Dr. Ananya Banerjee, and some of you on the call, Dr. Cohen, Dr. McGuire that I saw earlier, are also part of this really incredible team for the CIHR funded study. And to give a little bit of context of this, so essentially, you know, a lot of children that we see currently kind of fit this profile, but every story is so unique. And we always talk about the importance of understanding the uniqueness of each story, which also speaks to how in research we have to understand that uniqueness and the, once again, intersectional backgrounds that everyone brings to their story. So this is a 3-year-old boy who comes to Canada with his mother as a refugee claimant, born in South America. The mom was originally from Haiti, but had to leave due to the earthquakes and also the geopolitical kind of instability. Mother speaks Creole, some French. They basically walk through, you know, a dozen countries, survived the Darien Gap, crossed Mexico, the United States, and came to Canada to seek refuge. And as some of you may know, the Darien Gap is this 100-kilometer deadly jungle. If you ever want to watch a really powerful and important the kind of visual of this, the Migrant Trail to America, the whole story on CNN is a good one that you can find on YouTube. But essentially, this family comes and they've survived. They're resilient. They come for multiple ED visits for viral illnesses, and so they're brought to the attention of a specialized pediatric migrant health clinic. Otherwise, it's difficult for refugee families to access care in Montreal as well as in Toronto and other big cities in Canada, where oftentimes the interim federal health program, which is their health insurance, is not accepted at just any walk-in clinics. So the child has developmental delays. From the perinatal story, you kind of suspect that they have cerebral palsy. Multiple specialists are consulted and multiple tests and investigations are ordered. And this is a reality of our world today, that there's 110 forcibly displaced people worldwide. And of these, 43 million or 40% are children, and 2 million children are born as refugees. In Canada, I have here the top 5 countries in Quebec, which are similar to the top countries where a lot of our refugee claimants are coming from in 2022-2023, being Mexico, Haiti, Colombia, Turkey, Venezuela, Iran, India, Pakistan. And this is why our healthcare system is so confusing, because we have different types of refugees. So you can be a resettled refugee, you can be a refugee claimant, you could be a landed immigrant, and you could have non-status. And according to each of these categories, you have various types of healthcare funding. So not only is it very confusing for families, but also for healthcare providers who don't understand the system and who either don't subscribe to IFHP, which is the interim federal health program, and don't therefore care for refugee claimants, despite the fact that
because I need to pay.
It's exactly the same kind of remuneration that we get and things like that. So I spoke already about the barriers to primary care for IFHP patients. And you know, stories of families where basically it's traumatizing for them when they go to the emergency room, when they go into healthcare services, because they are basically told to pay or they're turned away and they just are afraid. And they should be afraid, because we have posters like this at our hospital, which essentially, and this is not unique to our hospital, this is across Quebec, where if you don't have insurance, one ED visit is $1,000. And so beyond those kind of clear barriers to care, migrant children and families experience racism, discrimination, language, literacy, and cultural barriers. They, once again, have a lack of knowledge of the healthcare system, but then again, so do we as providers. A mistrust of services potentially, the lack of provider knowledge and skills, as I mentioned, and there's other structural barriers. And so the mother calls now to you in a panic. The lawyer has misfiled papers, and if they don't submit claims by tomorrow, you know, their claims are going to be invalidated. And so how do you respond? And so our system, you know, has some safety nets in place, but we don't necessarily have all the safety nets in place. Especially if you know, the family reached out to me, I may or may not be able to help them with that in a very timely manner. And so our solution to this has been patient navigators who essentially reduce barriers to care. They are people who help patients navigate a complex system, access to care, overcome barriers. They interface a lot at the patient level, but they also interface at the community level, develop relationships and networks, and also potentially at the macro level where they may advocate for a wider policy change. They may involve, the patient navigator themselves can be a health professional, but they can also be a lay person, a peer of the community or a community health worker. And a scoping review of published navigation interventions for immigrant and minoritized ethno-racial communities essentially showed that there were improved outcomes with patient navigator interventions, such as for type 2 diabetes, but none of these studies focused on children and youth. So we had done a few kind of small pre-post studies to look at what a newcomer navigator could do for migrant families. And in 1 year, we looked at families that had experienced a navigator versus those that had not experienced a navigator the year before. And essentially, in our very small analysis, you know, there were a decrease in no-show visit rates to our clinic, as well as in ED visit rates. And in qualitative interviews, our families also reported positive experiences and how the navigator was able to help them mitigate additional care barriers during the COVID pandemic. Dr. Solomon also showed in her studies that were not focused on migrant children, but on children with developmental or mental health concerns, that navigator skills involves, you know, someone who had empathy, who had a strong knowledge of the system, who had strong communication and good advocacy. And that in their study, when they looked at who, or when they asked qualitatively providers who may have require greater support, migrant populations and families facing financial and language barriers were identified. These studies, once again, were quasi-experimental. They were, you know, there were confounding variables. It was not using cost. There were no costing data. And these navigators were really created organically with no structured training, no structured intervention, and without really involving families in the co-creation of the study. So that's where we came about with our study to look at children and youth with special healthcare needs who are children, you know, who are at risk of having more healthcare related use, and who have had, as a result, have more transitions within the healthcare, across healthcare systems, and may experience kind of adverse outcomes from these transitions between acute care, secondary care, primary care, and community care, resulting in unnecessary ED visits, increased hospitalizations, worsening of their disease, duplication or delays in their services, caregiver stress, financial difficulties, etc. So our study has 3 parts to it. There's the co-design of the navigator intervention, followed by the randomized controlled trial looking at the effectiveness of the navigation intervention, followed by an embedded qualitative study to explore the perspectives of families who had experienced versus those who had not experienced a navigator intervention. And we use kind of principles of CBPR to co-design our intervention. And essentially, I'll just skip to, you know, ways that our families have been involved. We had parent partners who were applicants on the grant. They once again helped us design the intervention. They helped us do the job posting, the hiring, the training, and also really gave us important feedback on the questionnaires and the outcome measurements. And then in our ongoing future implication with them, they'll be involved in analysis, interpretation, and knowledge mobilization. And that logo was made by the Community Advisory Board in Toronto of parents. And these were some of the competencies that they kind of helped us develop for our patient navigator, and some of the general duties that they identified. So some of the kind of key lessons that we've learned from working with our families is that, you know, it's important to be accountable, to have co-ownership of the kind of data, results, property, everything that we've created together. We enter this with a lot of humility, with a lot of reflection and flexibility as well. Sometimes we meet parents, you know, by telephone at night. Sometimes we do it during the day, whenever is in person versus over the phone or online. We do provide equitable compensation as well as language interpretation and translation. But it does take a lot of time, and REBs are not always familiar with these processes, nor are our academic institutions in terms of, and also the grant funding agencies acknowledging the time and the costs it needs to do all of this. And also to, you know, what we've learned is also to try to value our, right, sorry, once again, sorry, the idea of value has to do with academic currency and how this is not necessarily always as valued in our academic institutions. And then ensuring that we do constantly reflect on our positionality and navigating these in our relationships. So through all of our discussions, remembering that we're coming in with, you know, this position of being the researcher and the research team, but at the same time trying to equalize this power dynamic and ensure that we are really co-building and co-learning and co-developing our research together. So that's essentially our study. And I guess to end off with this slide, I think, you know, just reflect on how we kind of really do research that ultimately impacts the care of that we provide and the outcomes of children. We have to constantly, as research and academic institutions, acknowledge kind of the privilege and perspectives that we hold, and that how these may, you know, privilege some and exclude others, essentially. And thinking about who is part of our institution and who is not, who's being represented in our populations, in our studies, in our teams, and who is not, and calling out on this, and really working towards addressing these disparities. And like I said, once again, you know, critical for us as researchers and clinicians to consider the privileges that we hold as researchers, as part of kind of academic institutions in pediatrics, and how we've benefited from the system, and so how we will also elevate others and strengthen others so that they may benefit as well. I think that is the end, and I'm sorry I ran out of time. I'm going to stop my share.
Thank you, Dr. Li, for an outstanding presentation. You covered a lot of really important ground, and really appreciate in particular how deliberative you've been in framing all the work in a participatory, inclusive, anti-oppressive framework that really values the lived experiences of the individuals that you work with clinically and in your research. So unfortunately, we're over time, so we won't have time for further questions. But I just wonder, Patty, if we could, if any, maybe we could throw your email in the chat box. And I'm sure people will want to reach out for further discussion, collaboration, and opportunities.
Wonderful. Thank you so much again for the opportunity. I didn't really, so grateful. And the audience, I'm just in awe of everyone who's here. And so I was very, very, very nervous because I know there are very important people doing very important work in this audience, and with your center, the Leong Center as well. So thank you for this platform. I'm sorry I ran out of time. here's my email.
It's okay. Happens all the time. And we'll have you again.
We'll have you
Okay,
again,
thank you.
Patty.
Thank
Great
you.
work. I apologize. I have to run.
It's okay.
Bye,
Thank you.
everyone.
Thank you.